Then, how do we manage that acute stroke? Let's kind of go through the ABCs first. The first part of this is airway. So managing the patient's airway, what kind of things are we going to do there? Some of the common causes of hypoxia in your patient who's had a stroke include partial airway obstruction. Okay, this is kind of that whole sleep apnea kind of thing, right? Okay, your patient has maybe a small airway to begin with, and now because of this neurologic disorder, the patient's got relaxation of the upper airway. That relaxation of the upper airway then is allowing the airway to start to collapse, and we get some partial upper airway obstruction, causing hypoxia, worsening the stroke. So watch for that upper airway obstruction. Big red flag, big key here, it's not going to be hard to find. Listen for snoring. Your patient's snoring, and I've seen this before. Haven't you seen patients like this? You walk past the room, you can hear them halfway down the hall, can't you? And then, while you walk past the room and everybody, oh, well, yeah, he's the one who had the stroke. Well, this is a big problem. We don't want him in there snoring away like that. That tells us we have a partial airway obstruction. This patient could be developing hypoxia when he sleeps, just like your patient with sleep apnea does. And that's going to worsen the injury that's occurring because of this stroke. Okay, hypoventilation. Because of the stroke, the patient may not be breathing as fast as they did. So in other words, the respiratory center is involved, and now the patient's got a decrease in respiratory rate. Aspiration. Another big problem with our patients who have stroke. Let's get that head of the bed up. Put an NG tube down if necessary. Watch for potential aspiration. Now, the second part of aspiration is that maybe it's not a big gross aspiration that you might assume might happen. So in other words, the patient didn't vomit and aspirate. Instead, we're getting little micro aspirations. One of the things that we've learned about hospital-acquired pneumonia is that one of the ways that our patient develops it is by micro aspirations. Little mini aspirations, little bits of GI contents coming back up at a time, going down the trachea, getting into the lungs, and then causing infection. So these are little micro aspirations that can occur. Consider the fact that 70% of the population has GERD. 70% of the population has reflux disease and has GERD. Okay, so a lot of our patients out there are having these little micro aspirations occurring all the time, and this could be happening to your stroke patient as well, which predisposes them to develop pneumonia. Of course, that's another one of our complications. Atelectasis would be another complication that we have to be concerned about. So good coughing, deep breathing, incentive spirometry, turning, positioning, ambulation, move the patient. Good pulmonary hygiene is going to be important. You go into this patient's room today and you listen to the basses in the back and you're hearing diminished breath sounds in the basses in the back. Okay, big red flag there. We got to get this patient doing something because that atelectasis can lead to hypoxia, which then can lead to worsening the neurologic condition, the neurologic function. Okay, how about the breathing part? Our patients who have stroke could potentially develop breathing problems. The patient may stop breathing. They may have airway dysfunction or airway problems where we have to put them on some kind of ventilation. Now, positive pressure ventilation can be delivered by intubating the patient in mechanical ventilation, or we can deliver positive pressure ventilation by CPAP or BiPAP. All of these different types of positive pressure ventilation will change the pressure in the thorax. Okay, so follow me with this for a moment here. When you have normal spontaneous ventilation, normal spontaneous respiration and ventilation, okay, you take a breath in, diaphragm drops, chest wall expands, you create a negative pressure or vacuum in the chest that sucks air in. Okay, that's normal spontaneous ventilation. However, when we put our patient on BiPAP or we intubate them and we ventilate them and we're giving that patient the breath, now we're pushing air down. So instead of creating negative pressure, instead of creating a vacuum, now the vacuum in the chest that you make by inhaling is also going to suck venous return back up to the heart. But we push air into the lung, and now we're going to be pushing on the mediastinum and keeping venous return away from the heart. You with me so far? So the diagram is illustrating the fact that now we have all positive pressure in the thorax rather than negative pressure, sucking air in, positive pressure is pushing air in, which means we also have positive pressure in the mediastinum. And that positive pressure in the mediastinum is going to decrease venous return. Okay, now that will have a negative effect on cardiac output, but it's also going to affect our neuro patient because having an increase in intrathoracic pressure, increase in mediastinal pressure, will decrease venous return from the head too, which will actually encourage or contribute to cerebral edema. So we have to be careful with our positive pressure ventilation. The more positive pressure ventilation we use, the higher the intracranial pressure is likely to go. So we want to try to keep our intracranial pressure down. One of the ways we can do that is by trying to limit the amount of positive pressure ventilation we're giving to the patient. Okay, let's go back to that case that I told you about before, the 28-year-old who overdosed on Vicodin and on alcohol and who aspirated, had ARDS, sepsis, she had shocked liver, so now she's got a hepatic encephalopathy, a lot of stuff going on, right? Okay, we want to try to perfuse the brain. We want to try and get enough oxygen to the brain. But the more mechanical ventilation we use, the higher the intracranial pressure goes. So, it's a balance. How high do we need the oxygenation versus how much higher is it going to make the patient's intracranial pressure? So we had to balance this and say, okay, we're not going to use as much pressure because it's going to increase intracranial pressure, and we may not be able to oxygenate as well. And in this case, we actually were able to assess that well by looking at the patient's intraparenchymal monitor and looking at actual oxygenation of the brain. Okay, we're not going to know that.
You're saying that she was fine at 88% in the pulse ox.
She was fine with an 88% pulse ox, which you wouldn't expect. Okay, but we couldn't do any better without increasing her intracranial pressure significantly, which then decreased her perfusion and actually decreased her brain oxygenation. Isn't that interesting? Okay, now blood pressure, this is something obviously that is going to be kind of a catch-22 here as well. Normally, we are going to say that we want to have a low blood pressure in our stroke patient or in any patient who has got cardiovascular disease. So, for example, you've got a patient who comes into the clinic and they're just being followed up by their family doctor. We're going to try and maintain a low blood pressure in that patient. We don't want hypertension. The patient who's got a heart problem, same underlying disease process, atherosclerotic disease. But we're going to want to maintain a low blood pressure in that patient, right? We want to try and keep blood pressures low. And then here we have the stroke patient, in which case we're going to try to keep the blood pressures higher so the pressure will overcome the pressure in the head. Does that make sense? So in general, what we're talking about here with blood pressure is we want a systolic between 150 and 180. Okay, so that's going to look a little uncomfortable because this patient's got heart problems and this patient's had a stroke, and now we're maintaining a blood pressure like 170 systolic, and we all get nervous about that, right? We start seeing systolics of 160, 170. We think that patient needs treatment because we're trying to keep our blood pressures lower. There are situations with stroke patients where we will actually give them medication to raise their blood pressure and to get it up to 160, 170 in that range so that we can better perfuse the brain. Okay, so the situation here that's going to occur with blood pressure is we don't want it to be too high. So generally, we're going to treat it if it goes over 220. But we don't want it to be too low because then we're going to not perfuse the brain. So the blood pressure part is going to be really tricky. We're really going to have to balance this well, because if it's too high, the patient will pop a vessel and bleed. If it's too low, we won't perfuse the brain. It's a catch-22. Okay? Keeping in mind that your patient who even has the ischemic stroke, we're not even talking about bleed yet, okay? We're just talking ischemic stroke. That patient's going to have fragile vasculature. And that fragile vasculature is going to be more likely to pop and bleed. Okay, so we don't want it to go too high. But on the other hand, we have to maintain it to a certain level